When I was doing my endocrinology, hardly any data was coming on so-called polycystic ovarian disease, and we did not even have a definition for it. We do not have even a proper understanding for it. So it's a real pleasure, as Dr. Tripathi was just now talking about, looking at molecules not only from the point of view of taking care of the metabolic components of diabetes, but also simultaneously addressing the weight, which, some of the worst obesity we have seen is in the area where Dr. Tripathi is living, San Antonio and Texas. There was just look at it. In 1980, when I was a postgraduate, and 2011 when I left SKIMS, this write-up in Reuters in New York published. Hardly anything was known in the 80s about this particular disease process, and hardly anything was talked about. And then, steadily, the problem became to a status where today, the commonest endocrinopathy in women is polycystic ovarian syndrome. And this whole gamut started with the same expansion of those metabolic diseases, non-communicable disease, the root cause in most being that obesity that we have been alluding to for quite a few years, that has been eluding us for quite a few decades now. Not that all patients with polycystic ovarian syndrome have necessarily obesity, but quite few have, and most have. This is a paper that we published more than 2 decades back, where we showed, yes, a significant number of people are becoming obese in Kashmir. But what surprised us that women were 3 times more obese than men. And that really surprised us, because we thought, women in the Indian subcontinent are not being taken care of. The magnitude of nutrition is not that good. And so we were surprised that against 7.1% Kashmir adult being obese, males, 23% of the females were obese. And much later, a group known as Non-Communicable Diseases Collaboration Group, which we have been a part of for more than a decade, published how obesity has been globally behaving in the last half a century. This paper that this group published in Lancet in May issue 2016. We have been a part of this collaboration group for more than a decade, and this is being monitored from Harvard Medical School and Imperial College London. And it showed some fascinating things. We are interested predominantly for India. If you just look at this slide, on your left side, look at the magnitude of obesity in men. In the whole trajectory of different nations on this globe, India was at position number 19, which literally would mean that if you look in terms of absolute obese individuals, in 1975, even Germany had more obese people than us. Ukraine had more obese people than us. And now Indian men are at position number 5. Means the nation, we are getting obeser. It's not that rest of the world is not getting obeser, but we seem to be getting our bit now with vengeance in the last half a century. And if this was the situation in females, males, what happened to females? Look at it today. If you look at 1975, Indian women also were at position number 19, meaning that if you look at different nations in terms of absolute number of obese women, we had the 19th position in that trajectory. But today, after China and the United States, we have the highest number of obese women. And that's why today every gynecologist, every physician is looking all those ultrasounds with polycystic ovarian syndromes, getting referred to people right, left, and center. This is a paper that we published a decade after the last one, where we looked at relatively youngish people. Again, we saw that this obesity is taking off early, and there's a difference in this obesity between boys and girls. And later we published a paper where we studied children from 5 to 15 years. This trend was not as marked in them, in boys and girls, but the trend was there on the higher side in the females. Then in that global data that I alluded to, we looked at obesity globally. In children, adolescents, and young adults, situation globally exactly same. Much worse, obesity getting worse and much worse in females. When we look at how we make a diagnosis of a polycystic ovarian syndrome, it has eluded for a long time clarity, and I believe still continues to elude. NIH made an attempt in 1990 and very grossly underlined some clinical features, investigative features. And then a group of guys met in Rotterdam in 2003 in Holland. And today, predominantly one definition that we hold today, Androgen Access Society 2007 guidelines. But what does it in real terms mean? You have a suggestion of hyperandrogenemia and hyperandrogenism and anovulation, a very broad thing and not a very precise thing. Oligo or anovulation and clinical or biochemical suggestion of hyperandrogenism may or may not have, and polycystic ovaries invariably would have on an imaging tool. But also it says that we have to exclude other conditions that are likely to give a scenario like that. Cushing's syndrome, hyperprolactinemia, hypothyroidism, non-classical congenital adrenal hyperplasia, androgen secreting lesions. But if you look at those exclusions and look at the level at which we diagnose polycystic ovarian syndrome today, these numbers for these disorders would be extremely minuscule. So many times, now today, the first thing that attracts this attention is this thatch of hair on the face. And the criteria that have been given by the Androgen Access Society, which again emphasized you need to have a clinical or biochemical suggestion of hyperandrogenism, ovarian dysfunction in the form of anovulation or oligoovulation, and a polycystic ovarian morphology, and exclude those clinical or pathological disorders that are likely to lead to a similar situation. Epidemiologically, depending on what subset of population you are studying and which criteria you are using, you will get different figures. Understandably, when you look at amenorrhea, when you look at oligomenorrhea, different percentages would come. But by and large, if you look at Rotterdam criteria or Androgen Access Society criteria, 10 to 12% of the people were said to have a possible diagnosis of polycystic ovarian syndrome. And I do believe, ever since this paper was published in Human Reproduction, probably the numbers have increased, the percentage has increased because the obesity has worsened. A very complex disorder, not obesity alone. Yes, a lot of data shows that this particular pathological process is associated with insulin resistance, which will come down to very soon. Is it a generalized insulin resistance? Some people have been believing that it's a more sectoral insulin resistance in the ovarian tissue. Is this fundamentally an ovarian defect, which ends up in creating more sex steroids, androgens and estrogens that start the vicious circle, or a peripheral cortisol metabolism? But there's a significant thought and very relevant thought that it fundamentally is a neuroendocrine defect. When you look at GnRH from hypothalamus and the response of the gonadotropins to this GnRH and the response of the ovary to this LH and FSH in the ovaries is aberrant. Now, today, there appear to be very differently two classes of people. Why? Insulin resistance is predominant. Because of obesity, it is emerging a much bigger class. And there's a class where neuroendocrine defects may be predominant. It's a relatively smaller class. But again, there is no clear-cut demarcation between these two. Just look at it. Almost 100 years back, Gist published in American Journal of Obstetrics and Gynecology Bilateral polycystic ovarian syndrome is most probably a result of some hormonal stimulation and very likely relates to the anterior lobe of the pituitary gland. And much later, about 40 years later, studies showed, yes, in a big chunk of these people who had this polycystic disease of the ovaries, there was an excess LH activity in the plasma. Again, if you just recapitulate this is what I said. You have a GnRH, it acts on the pituitary. Either the pituitary is hyper responsive to the GnRH and causes more LH, or there is a defect in the feedback from the sex hormones, androgens and estrogens, into the hypothalamus that responds aberrantly to GnRH secretion. But this may still be debatable, the precise mechanism, even though a lot is known today, than was known 4 decades later, 3 decades later, 2 decades later. But what is unquestioned, that this is a clinical stage which is characterized by hyperandrogenemia, but also hyperestrogenemia, because that's the main source of estrogens is androgens. And that's why, you get endometrial proliferation and possibility of an endometrial malignancies and excessive bleeding, all that. Whatever the reasons for insulin resistance, whether they are genetic, autoimmune, some defects, hyperinsulinemia through different routes has been shown to cause a decrease in sex hormone binding proteins. So free testosterone is on the higher side, gives a hyperandrogen state. This also decreases in IGF binding proteins. So IGF is on the higher side, can cause ovarian stimulation. And this differentiation of a ratio between LH and FSH drives it more towards an excessive production of androgens. A lot of data right from 80s has shown that almost half to 2/3 of women with polycystic ovarian syndrome demonstrate clinically measurable insulin resistance above and beyond as determined by their body weight. So there's something more than the body weight alone that does cause hyperinsulinemia. A lot of data has come up for the last half a decade, for the last half a century now. Firstly, those crude urinary estimations of LH. Now, ever since this radioimmunoassay came to the fore, particularly from 80s, PCOD, yes, is characterized by hyperinsulinemia, at least in most of the individuals. But presence of insulin resistance necessarily is not diagnostic, because it's so common otherwise also. Now, central to polycystic ovarian disease, as I said, is hyperandrogenism. From diagnostic point of view, not hyperinsulinemia. And this barrage of androgens have been studied: dihydroepiandrosterone, dihydroepiandrosterone sulfate, androstenedione, testosterone, blah, blah, blah. But probably one of the best to look at would be a free testosterone. This data suggests, are there any racial differences? This data published about half a decade back in American Journal of Obstetrics and Gynecology between different races. Yes, it was shown that in the United States, Hispanic women with polycystic ovarian syndrome have the more severe phenotype. Maybe Tripathi would be saying, Professor Tripathi, more of it, a lot of Hispanic, almost a Hispanic population in San Antonio, both in terms of hyperandrogenemia and metabolic criteria. Non-Hispanic Black women have an overall milder polycystic ovarian syndrome than Hispanics, and in some respects, than non-Hispanic whites. From clinical presentation, probably one of the first things that drives our attention is this patch of hair on the face. And this is a data that we published long back in Fertility and Sterility. Second commonest cause of hirsutism in that young age was polycystic ovarian syndrome. And quite few had would be characterized for idiopathic hirsutism. but PCOD was one treatable disease there. And then when a person comes out of that juvenile concern for cosmetics, fertility becomes an issue. And in this study published in Fertility, we found out that this was the most anovulation, because that time when we published the data, only NIH criteria were available, and tools for making a more refined diagnosis were not there. But we documented anovulation, and 1/3 of total infertility was associated with infertility, which was not associated with any form of ovarian failure, but LHFS is characteristics of polycystic ovarian syndrome. And when that fertility issue is settled, insulin resistance is there, gestation diabetes many times more in these women. So that issue needs to be handled with a different thought process. And once that issue is taken care of, overall, now diabetes is much worse in these people. As I told you, data shows that firstly, a good chunk of them are obese. So obesity-related insulin resistance, there are a lot of studies have shown creating an equipoise in body weight or body mass index. Women with polycystic ovarian syndrome have a much worse insulin resistance than women who do not have a polycystic ovarian syndrome, but have a similar body profile in terms of waist-hip ratio and body mass index. And there's almost 40% people will be developing diabetes by 40th birthday. Now, this is a data that, again, sort of concerns me in my own country, that now this epidemic, this is a paper that our group published in Nature, and a year before this COVID epidemic, we showed that now urban and semi-urban areas are saturated with obesity. Whoever has to get obese is already obese. Now the juggernaut is moving to the rural area. McDonald's is moving to rural area. KFC is moving to rural area. Biryani is moving to rural area. And now that will in future drive the obesity. And now when that happens in India, because still most of the India is rural, we will have a much worse problem at our hand than we have been seeing for the last couple of decades. And not only that, now it's not the only consequence that we look at it from anovulation, we look at from diabetes, fertility, gestation diabetes, permanent diabetes, the associated epidemic of coronary arteries in the country, which has doubled up in the last 2 decades. Consequence of that same metabolic disorder, dyslipidemia, hypertension, and diabetes. So in conclusion, if you look at this polycystic ovarian syndrome, it's an insulin resistance syndrome that is characterized by hyperandrogenemia, but simultaneously also has significant components of metabolic dysfunction. It might incidentally be associated with reproductive dysfunction, but also has dyslipidemia when their body mass starts increasing. In those youngsters, you certainly find out a TG of 250 at 15, 16 years, and 18, 350, at 21, 400. And we have seen it, and I'm sure many of you have observed it in the hypertension very early. Now, gone are the days when you say essential hypertension beyond 30, almost starts occurring a decade or a half decade earlier. Central adiposity has become so common. It was already in the Western world assuming huge proportions, but is now assuming big proportions in our country also. So in totality, if you look at the total lifespan of a patient with the polycystic ovarian syndrome or tendency, right from the beginning, youngsters, in that 6th, 7th class menstrual irregularities, and then that thatch of hair on the face, predominantly, looking at dermatological, that cosmetic, and then those menstrual irregularities, and going from gynecologist to gynecologist, getting different hormones, and then someday getting to an endocrinologist, and then certainly, some form of dyslipidemia or dysglycemia. And then the consequences as the age goes by, decade by decade. Huge problem. In conclusion, I must tell you, emerging problem. But unfortunately, when we have the time to reverse or control or treat many of these components, most of us lose these components because we spend a decade on that hair growth and electrolysis. We spend another decade only on that anovulation and proper menstrual cycles, but never give a consolidated concept either to ourselves or to our colleagues, and more importantly, to our patients. Thank you so much.